Okay. Okay, here. So this study is only one image, so we go against the basic principles, but I think it's worth. And I hope, I went through the cases and I don't remember, I couldn't find this, but I remember talking about this case. So it may have been in a previous life or whatever, but so if we've already talked about this one, just let me know. And then that's why I put another case just in case. I couldn't remember exactly. I went through the list of cases and I couldn't find it, but I don't think there are all the cases in there. There were a bunch of cases that they were not posted in that forum. So, we'll see. So I'll give you the history. Well, you had the history there, but let's remind you. So basically, this is a young cat hit by a car. Topics. Yeah. So it's a 3-year-old domestic short hair hit by a car that presented dyspneic. That's the history. It's only one image for now. Yes. And then in the meantime, while you take a look, I'll post the link. So for those of you that are not familiar with the forum, you can click on this link and open the images. That was here, and it was in the chat here. Paste. There you go. My job is done. Now I'm all ears for my paper and my pen. So there are many, many things. Yeah, and we'll see how it goes. So I guess the question, if it's normal or abnormal, I guess we skip this one today because it's clearly abnormal, but then we'll see.
The first thing that jumps out to me is the fact that the heart silhouette is elevated.
Okay, good.
And I know I've seen that before because of positioning. So to make sure that it's not positioning, I can see that the ribs are in alignment. So it's not like it's twisted. So that makes me think that it is actually truly elevated.
Okay, cool.
I'm having trouble following the ventral aspect of the trachea to the bifurcation. It feels like that's somewhat absent, kind of near the base of the heart, where there looks like there's maybe a pocket of gas.
Mm-hmm. Okay, so kind of interruption in the continuity.
Then the diaphragm looks flattened in the dorsal margin of the thorax. The gas filled area goes past the 13th rib. So it's like there's more in the chest than there should be.
Okay, so kind of an increased thoracic volume.
Yeah.
Okay, cool.
Yeah.
And then the kind of the evidence for that is the caudal displacement of the diaphragm flattening.
Yeah.
And then probably the other one that I would add, just as a reminder, is kind of that separation of the diaphragm from the heart, which is not that obvious in this case, but that's another hint. Mm-hmm. And then there is another hint if in case you have the other projection, which will be kind of the ribs gets perpendicular to the spine. So those are all hints, kind of indirect hints to judge the volume of the thorax. And I agree with the comment. So increase thoracic volume.
Yeah.
Mariano, in that, or looking at those hints, subjectively, the cardiac silhouette looks smaller than normal as well. So you start thinking, well, is that because the sort of there's the thoracic area is enlarged, or whether the patient may be dehydrated? I always think of Addison's when I see a small heart. But is that another hint that it just relatively looks smaller? So first, I agree with your statement. So our subjective assessment of the heart, and I think it's an unconscious thing,
is in relation, is kind of, we have a mental representation of how the heart should be, and that mental representation is hand by hand with the size of that dog and the size of that thorax. So whenever there is an expiratory radiographs, like in relation, the heart looks larger compared to the thorax. And whenever there is an inspiratory study, the opposite happens. And then similarly, when there is something creating that increased thoracic volume, then, but having said that, I agree with that statement, doesn't mean, actually the way that I would use that is to be careful in my assessment of the heart, because I think I can be fooled by that, rather than using it. Makes sense to me? Because, and I'm not saying that in this particular case, the heart may be affected. What I'm saying is, I'm trying to be careful not to be fooled by the normal changes in the thoracic volume, subjectively impacting my assessment of the size of the heart. Because again, so if you think about normal and abnormal, and in between the normal and abnormal and anatomical variation or physiological variation, then that comment about inspiration or expiration, the changes in the thoracic volume impacting our assessment of the heart, of the size of the heart, then all of that falls into this gray area, which is gonna make our life difficult to separate normal from abnormal. I don't know if that my comment makes clear. So in other words, I will not use that as a hard feature to support my evaluation of the heart. Actually, I would put that as the opposite side of the coin. I will be, whenever I detect a change in the thoracic volume, that makes me very concerned about my assessment of the heart, because I may be fooled by that. Makes sense? So the size of the heart may not be actually affected. It may be my assessment because of the changes in the thoracic volume. I don't know if I was clear enough.
No, that's great. Thank you.
And then, so then we talk about, so these are all arguments. So which would be my strong argument? You know, how can I escape this situation and say, well, if that makes me be concerned over. So then when we talk about the heart, then I always look at for me, the most important thing is, can I see vessels, and are the vessels telling me any story? You know, what about the pulmonary arteries? What about the pulmonary veins? What about the corvina cava? You know, that, and then more like hard evidence. So for example, the intercostal spaces, the shape of the heart, and then in this case it's limited because we don't have the eye projection. But I'll probably use those features and try to stay, and then take the other ones with a grain of salt. Makes sense. The other one I will be very careful. In my eyes, they operate in the opposite direction. They make me concerned, not to be fooled. Okay. Anything else? There is more stuff. And probably another thing that I kind of let go, but now that we are trying to clarify, is the comment about the elevation of the heart. And I really like the comment about, because we need to be aware of all of this, you know, talking about being full. Is it real or is it not real? So then that comment about, is it rotated? Because, you know, can the heart be elevated and not actually be meaningful? Is it an artifact? So then there was a mention about the rotation, and then how to get away from that problem, which is to see if the radiograph is rotated. The other differential, the other consideration that we should have, again, trying to escape the possibility of being fooled, is that an anatomical variation, which is not common in cats. But if you are dealing with a situation like this in a dog, the other consideration that we need to have is the conformation of the thorax. So the classic example would be where this can occur, where this separation of the heart from the sternum usually occurs. The classic example is going to be a deep-chested dog, like a setter or a Doberman, like a very thin, It's a very inspiratory study. So basically what may happen is that actually the lung lobes kind of wrap around the heart. And then that wrapping around the heart results in the elevation of the heart. And again, I'm bringing this because the rotation and that particular anatomical variation are two normal variations. So we shouldn't try not to confuse a normal variation with an abnormal finding. Again, we are in this line in between normal, anatomical variation, and abnormal. Makes sense? So this struggling about where a finding belongs is an important thing. We always struggle with this. So it's good to consider, this is my finding. We haven't talked about what is the, what do we think about, Alex? Like, how do you read that change? But I wanted to make sure, once you find that change, the concern that we need to have is that there are two possibilities, two normal variations, let's say, two situations where that feature is not abnormal that we need to keep in mind.
Yeah, I didn't know about the deep-chested dog thing, so that's interesting.
Actually, I believe that is a lot more common, because even though I let the rotation go, I'm actually not sure. I probably would argue that it may not result in elevation of the heart, but because once you rotate, I think, yeah, I'm not sure, but because I'm not sure, I haven't said I don't think, I think you're wrong. I think it's a good thinking. When you rotate, things look in an abnormal place. I'm not 100% sure. It may result in a rotation like this, but it's worth considering, and it's worth, we don't need to be always right, but if you consider and you have a tool to get away of that doubt, then that's the good way to do it. So that's the consideration. Can it be, it doesn't matter if it's right or wrong, you just consider it. Is it possible that this image is because it's rotating? And then the way out, you may be able to get out even without having the hard knowledge if a rotated radiograph results in elevation of the heart, just by saying it's not rotating. Makes sense? And I have my tools to decide if it's rotating or not. So then I just cross that out, and it doesn't bother me anymore. Okay, anything else? So, yeah, sorry.
I was just going to say that I think there's hemorrhage in this chest as well. And I think probably normally I would think the heart would be elevated because you're worrying about a pneumothorax. But I think in this case, you've got more evidence for hemorrhage sitting underneath the heart. You've also got changes in the lungs in the quarter-dorsal area. As you know, I'm always struggling trying to tell you exactly what I'm looking at here. Hang on, see if I can do this a bit better. So, cool. In this sort of area here, you've got what I think are, you can see some airways in there, and you've got quite a lot of hemorrhage around those airways. There's lots of lines that I'm struggling with in this area that I can't define what those lines are, but I'm presuming they're a mixture of air and hemorrhage and lines between lung lobes. I can't define it any better than that, but that's my input.
Cool.
The aorta is unusually highlighted, so there's obviously more air around that than there normally would be, but the lung patterns, go to the edge pretty well. So I'm thinking that the lungs are over aerated rather than free air, because free air normally doesn't appear there.
Okay, so excellent. So I think there are now 4 questions or things that we need to make a call. So one is this idea about, is there pneumothorax, or is there perfusion, or is it both? Those are, so there was this question about, let's say, pleural disease. So is there pleural, is all pneumothorax, is it pneumothorax, is it pleural effusion, is it both? I don't know. So that stay in the air. So I invite anyone to untangle that. And then the way to do this is, again, that's why we read the book. We need to be very familiar with the features of each of these diseases and see if we find them or not. And then to see how they operate in this particular case. So that's one. Then the second is the changes in the lung. So then I see what you mean. So then the next step will be, how can we explain that in the context of what we have? What are the possibilities? And then we go yes, no. And then the multiple lines and the discussion of the aorta, we see where I see what you mean. And we see if anyone has anything to offer in terms of an explanation for that. So, this again, I was trying to unpack all of those comments, and I think they fit in these groups. Make sense? So one group is pleural disease, all pleural effusion, all pneumothorax, both. We need to discuss that and see if we can get to a conclusion. Then the other one is there are lung changes. I see them. What could they be? How can we read them in this context? And then the other one is there are too many lines, probably in the caudosal thorax. What's our assessment of that?
I guess, Mario, from your first question about, do we have pleural disease or not? And is there fluid? It does look like a fluid or soft tissue density, ventral to the heart or this area here. But if it was fluid, then my question immediately is, well, how come I don't have any effacement of the cardiac silhouette? I can still see things really easily, unless perhaps it is just with gravity gone ventrally and perhaps organized itself somehow and it hasn't infiltrated in the rest of the pleural cavity. I liked Jeff's idea with their aorta. Is it really super aerated lung? Because again, I initially thought it was a pneumothorax, but I agree with Jeff that the lung lobe looks really defined. I guess we need the other view. But yeah, this sort of, the main thing that I was looking at was this soft tissue fluid density ventral to the cardiac silhouette, but I can see the cardiac silhouette. So that's unusual for me.
I think that's a beautiful way of thinking. So perfect. So if you think about fluid, and that is fluid, they should be silhouetting with a cardiac silhouette, and it's not silhouetting. So we need an alternative explanation. Something that I will probably add to the equation when we are talking about is there pleural disease or not, is if you go back to the features, and you've done that. So basically the features of pleural effusion are going to be silhouetting of the cardiac silhouette, silhouetting of the diaphragm, and the pleurofacial lines. So in this particular, so that one, which is the silhouetting of the cardiac silhouette and silhouetting of the diaphragm, is not there. So that's a good, like a point off, is an argument against, which I clearly agree. Okay, I think we need to now, before I was about to keep going and make a call, and I don't want to make the call myself. So there is the discussion about this caudodorsal thorax. What are the possible explanations? Just to refresh.
I think it's a pneumothorax at the top, because there's no pulmonary vessels in there. You can see the aorta is highlighted. And I think the lungs look whiter because they collapsed. There might be pulmonary contusions as well, but you can't tell at this stage until they're reinflated. So I think the cat's got a massive pneumo, personally.
Cool.
Probably a tension pneumo.
Lucy, you know the answer to everything. I was like, when's Lucy going to come up with her answer?
I think it's got a tracheal rupture as well.
Yeah. I'm going to add a spanner in the works. Is this got a pneuma mediastinum, not a pneumothorax? Because it has got that tracheal rupture.
I think
And
I think it is a pneumothorax, but it could have a pneumomediastinum as well. It's definitely got a pneumothorax.
Beautiful.
The lungs are collapsed.
Cool. So from what Lucy said, the thing that I take is the first part. I think that's the strongest part, because she's not only saying, I think there is pneumothorax, she's saying why. Makes sense? So the discussions always grow if we can not only say what we think, but then support what we think. So the argument is, I think there is pneumothorax because there's separation of the lung, and then there is also increased opacity of the lung. So there are two strong arguments. I think the stronger one is the separation of the lung, because that's very specific. I mean, the increased opacity of the lung could be many other things, but the separation of the lung from the wall, then that is the feature of pneumothorax. So if we can, and then the thing is feeling confident about seeing it. So I would pick, for example, that line, and I think that line is separation of the lung from the wall. And the other one is what Lucy mentioned, is that we cannot see the vessels extending across those lines. So again, separation of the lung from the wall. So we usually don't see the border of the lung. It's against the wall. There shouldn't be anything. There should be a minimal amount of fluid that we usually don't see. Once we have something in the pleural space, the lung separates because of the elasticity of the lung, separates, and then we get a gap. And if we get that gap, then we see the border of the lung. The only situation that we should be very, very careful is not to confuse something like a skin fold that goes over, makes sense, and goes over the lung and then goes out of the thorax. Confuse that with the border of the lung. So in this case, I think it goes within the direction of the lung, and not only that, I don't see any vessel going across, and that is telling me that that has to be the lung. So yes, I agree with you. There is a separation of the lung. I would pick that as the border of the lung, and then that makes a pneumothorax. So then we have one more thing, and I also take the comment about the lung, because that puts that comment in context. So if we believe that there is pneumothorax, then we have an expectation of increased lung opacity because of atelectasis, because that lung is smaller, has less air inside the lung, and therefore has to be more radio opaque. And then I also completely agree with the consideration of, well, that is one explanation, but there could be also some degree of contusion. So that all fits perfectly. Now I want to make one observation that is the one that I almost did like a minute ago, but I kept myself from doing it. Is one of the, when I was mentioning one of the features of pleural effusion is the silhouetting of the cardiac silhouette and silhouetting of the diaphragm. The other one are the pleural lines. And in this particular case, when we decide that there is pneumothorax, then the pleural lines are not going to look like the normal pleural lines. Makes sense, because there is something else in that pleural space. So in order to have that pleural lines, that fluid accumulating between the lung lobes, then we don't need, that is a condition that requires no pneumothorax. When we have a lot of air in that pleural space, then the fluid and the air are going to move differently compared to only fluid or only air. Make sense? So I wanted to make that comment because, for example, in this particular case, I believe that there is no silhouetting of the cardiac silhouette, and I believe there is, I don't see any pleural lines. There is no silhouetting of the diaphragm. However, this increased opacity that is patchy, I think it could be a little bit of accumulation of fluid on the dependent side. That is not going against in between the lung lobes just because there is gas. Makes sense? Just because, remember that that fluid goes in between the lung lobes because of the capillary something phenomenon. So, and because there is no gas. In this particular case, where there is pneumothorax, then the fluid can just pool. So then our expectation about the pleural effusion or how it should look like in a situation like this should be different compared to a situation where there is no pneumothorax. So hopefully now we are rounding, putting things all together. The next thing that we have is, I completely agree with Helen's comment and Helen's certainty about there is a tracheal rupture. Perfect. So that inability to see the border of the trachea, it really stops here. So the interruption of the continuity, I think it continues here. So there is that gap. And then based on that, there was a discussion about, in a similar way that we had the discussion about pleural effusion and pneumothorax. Now we need to go a little bit into the discussion about pneumomediastinum and pneumothorax. Can they live together? What can we hypothesize happen? What is the sequence of events? Things like this. So
I'll throw something in from left field, Mariano. That is an unusual liver shadow there. And also the border of the liver is not distinct and marked. It's quite rounded there, unless I'm seeing something else over the top of it, like stomach. But then you can't see any liver behind it. Also, this airspace here, so the diaphragm line might appear to come. No, hang on. Where are we? The diaphragm line comes down there and then breaks and then seems to restart there. So tell me I'm talking bovine feces again.
So your comments about this, I think we are dealing with the stomach. I'm not sure why. And then again, we can get back to that concept of normal, abnormal, and in between we have a lot of normal variations. And so I think in this particular case, if you ask me about why is not the liver looking like usual, where we have this thing, I don't know. But so the way that I'm gonna run is gonna be, well, the opacity of this. So basically this, I expect to have the color border of the liver and then have the pylorus, that it has to be rounded. So that fits with the pylorus. The content, the opacity of the content fits with ingesta. So then I have two very strong features that, you know, fit with one situation. And then the other one that doesn't perfectly fit is that border of the liver. And then if you push me hard, then I'm gonna say, well, if I need to put that finding in these three compartments, normal, abnormal, or an anatomical variation, I'll put in an anatomical variation, which then I don't mind. And then here I think is a similar consideration. The opacity is that granular mixed soft tissue and gas opacity. I think that is very much how the ingesta looks like. This is a usually relatively normal appearance of the stomach. I think it all gets very confusing or very busy visually because of the pneumothorax, and then we see the sharp borders of the aorta and all of that. If we come here and we try to be more, to dissect that image a bit more. So I think that's the diaphragm probably sticks out as a very clear structure because there is gas on the other side. So that is bringing that border very, very clear. But then, and then that soft tissue, then the gastric wall is soft tissue, and in between, I think it's just fat. And it's less opaque. And that's what we call a good serosal detail. The next consideration is going to be, is there any pneumoretroperitoneum? Because if we thought that there was a pneumothorax, a pneumomediastinum, then that can dissect and goes along the aorta and then goes into the retroperitoneum. And in particular, I don't see that. Now, if we come back to this line, then I don't know. I don't know how to explain that. If you push me hard, then I'm gonna escape and say that's probably motion that we just got that radiograph when the diaphragm was moving, and one part moved more than the other, and that's why we have that interruption. I see the interruption, and I don't know how to explain it. The only way that I would probably explain it is by just making that up, saying that maybe there was some motion. However, The only other consideration that we should be very concerned is there any diaphragmatic rupture? And I don't think there's a rupture for a number of reasons. First, there is no displacement. I don't see any abdominal structure in the thorax. That's the first feature, direct. I don't see that. And then I don't see any of the indirect features, which would be any displacement of cranial displacement of abdominal structures and cranial displacement of thoracic structures. I don't see any of that. So then, again, if you normal variation, abnormal, I'm there again in the gray area, which is a normal variation or an artifact. Having this word comes to mind, having the guts to ignore things and to say, I put them into a normal variation, that is the summary of experience, which doesn't guarantee that you're always right. But that confidence comes after seeing many, and then you can be confidently wrong. So I'm not saying that, I'm pretending, you know. Yeah.
Yep. Thanks, Mariano. You learn more from mistakes than you do from getting the right
Absolutely.
answer.
Absolutely. So, and then the more you see and the more you question the things, then the more confident you're going to be to put one finding into one of these three compartments. And we usually undervalue the compartment of being able to not to pay attention to things, to consciously make the call about, I'm not going to pay attention to that because I think it's a normal variation. I think it's an artifact. That's tough. That's tough. Okay, so we come back to the pneumothorax, pneumomediastinum situation. And can we put that together with the, can we make up a story? Can we put, because I think we've got all the findings. Can we make up a story? Can we say, you know, this is first, this is second, this is third? What happened?
I don't think it's a pure pneumomediastinum because usually you get much better highlighting of the mediastinal structures than you've got here. It'd be pneumomediastinum plus.
You also
I
haven't got
agree.
subcut emphysema either, which you would expect if it had a massive pneumomediastinum.
Yes.
Okay, so now we are saying that there is no pneumomediastinum.
I'm not saying that. I'm just saying it's not only that. I mean, with a ruptured trachea there, then you know, you'd expect there would be.
And I agree. So, and I agree that it's a questionable finding. So the classic radiographic feature of pneumomediastinum, and we certainly expect to find pneumomediastinum in this case because we have a ruptured trachea, would be to have increased delineation, visualization of the craniomediastinal structure. So the brachiocephalic arch, the left subclavian, the esophagus, all of that becomes the aortic root. So all of that becomes very clear. So none of them is that clear in this case. I see the very clear contour of the aorta there, but in cuts that it may be a bit of pneumomediastinum that is there. So I think I have two explanations for that. One is that there is a mixture of pneumomediastinum plus fluid in that mediastinum, and then the fluid is avoiding that increased visualization, increased detail, and then the gas went more caudally along the aorta. Or the other differential is that there is actually no, is that rupture, that air that is escaping the trachea because there's a trachea rupture is being contained somehow. And I think you can make that argument, you know, that there is a very clear delineation of something. So maybe there is a component of that trachea, I don't know if there is a serosa in the trachea, but that layer of the trachea is holding that air trapped around the trachea rather than being free in the mediastinum.
There's been a couple of cases reported because you get like I think they call it like a pseudomembrane or something, so they have an accident and then like 2 weeks later they present dyspneic, and it's been ruptured all the time, but it doesn't become apparent till later on.
Perfect. Yeah, and I agree with that. I'm not familiar with the paper, but I think Helen, we've seen a trachea rupture together. I think that's the other case that is coming around my mind. Anyway, this is the classic appearance. It's the classic. First is cut, and then second is always in the same place in the intrathoracic portion of the trachea, and for some reason always, or the ones that I've seen, is always with that kind of pseudomembrane. I like that way of defining it. So if we believe that is the case, then the pneumothorax that we see is probably independent from the pneumomediastinum. So the same trauma that produces a tracheal rupture produces pneumothorax because of leaking of air from the lung, rather than air leaking from the trachea into the mediastinum and then from the mediastinum into the pleural space, which that can happen now as well. Okay. Okay, and the other thing that I wanted to show you, so any questions? I think we found all the features. I was very happy that you found the tracheal rupture first. And then I make these discussions long and probably boring because I'm always trying to go back into the justification, why we think the way we think. Because if the more time we spend dealing with those arguments, then I think that's how you build your toolbox. And those are going to be the arguments that you're going to apply in the next case. So, because the idea of this is to create this toolbox. That's why I spent so much time discussing about them and arguing against and in favor, and just letting you know what is in there will not help. I think discussing and then putting ourselves in one position and then the opposite position, that exercise helps building the toolbox. So the only thing that I wanted to mention is that, can you imagine being in the anesthetist's shoes with this case? Horrible. Horrible.
Well, I'm imagining that's why they only took one X-ray, because they were too nervous to turn the cat on its back or its stomach.
Absolutely. Yeah.
Do you know what happened with the cat?
Yeah, that's why I have the whole thing. I haven't.
Oh, cool.
And it's a very interesting story. Let me see. Okay, I think this is immediately post-op. They fixed the thingy there, the trachea. I think this is a bit later. So now there is no pneumothorax. It's a lot nicer. And then let me see, because I should have looked at this before and I haven't. But I know what happened with the case. Okay.
Did they fix the trachea?
Yeah.
Oh.
So let me see. So this was, I can open multiple. So this was immediately post-op. We know there's a draining drain, there is pneumothorax, there is increased lung opacity. So all of that is consistent with post-op. And I'm going to tell you what happened. This cat came after a while. So this is in July. This is still July. So this is not going to be, this is still July. So I may be missing the actual cool one. I need to do that carefully. This cat came with inspiratory dyspnea after a while. So it cannot be this. Anyway, so it developed a stricture there. And it was I think I have better images, and it's not these ones. So you could follow, maybe you can kind of see it here. So the trachea goes like this, and then there is like an indentation, and the lumen is very thin. I think I got another study that was a lot better. So this is kind of a normal trachea. The diameter is a lot less, or a bit less compared to here. But then here there is an increased opacity. So basically, this was a kind of, this fixing of the trachea resulted in a scar tissue, like a circumferential scar tissue, with a resulting narrowing of the lumen. And then that was clinical. And then I think they ballooned that. And then that worked beautiful. And then the cat never came back, as far as I remember. This was during my residency. This was this is a Zurich case. I remember because I love the case, and you know that you have some cases, and this is what I'm trying to do with these cases. So there, maybe you see the indentation better. I think that's real. But I recall we have better images. You know, there are certain cases you can read in the book, but that's okay. Then there's going to be a case that comes across that teaches you, you know, that's the case that you're going to remember. So this is the case that I remember having with the trachea rupture that I was involved, like actively involved. So then I remember everything, and then I keep it.
How did they anesthetize it? I can't get my head around how you would intubate that.
They intubated. They managed to intubate and inflate a little bit, inflate the balloon all the way. So they managed to do it. I remember discussing with the clinicians this case, and then the anesthetist came because he was concerned about, you know, how long was this segment and how concerned he was. But then they managed. I'm not sure how. I don't know if they scope it at the same time, and then they could guide while doing scope. I don't remember. I remember that was part of the conversation.
Maybe they use one of those single lung tubes, whatever they're called, where they like only inflate one lung, like went down past it. Don't know. Because normal ET tubes wouldn't go that far.
Yeah.
Yeah, we've scoped one before and we used dog urethral catheters, and he was oxygenated quite well. It was in a doggo though.
Yeah, it may have been one of these creative ways of doing it. I don't remember. I remember that, you know, these cool discussions in the clinic. I remember dealing with a case and then having people around, and then the conversation went into, you know, how to intubate, how to deal with this case, and then continue. And I don't remember exactly how they solved it.
Because it would have to be ventilated once you open the chest up, right? So you'd have to be able to form some sort of seal.
Good point. Yeah,
with the lung.
I'm trying to go now fast. See?
We'll have to ask Keely tomorrow, see what she would do.
Yeah. I think a guide wire. Like if you could do a radiographic or fluoro-guided guide wire and then a tube in over that and then inflate the cuff in the distal section of the trachea.
Just have like a super long ET tube so that the cuff was like in that second section maybe.
Yeah, exactly. Yeah, it'd have to be. But most cats you can intubate a bronchus, like the ET tubes are long enough.
Yeah, and I don't think there is any more
Problem with them, Anna.
Sorry?
That's sometimes the problem with them. They're too long.
Exactly. Yeah, absolutely. Yeah, we trim a lot of them.
You still have to have the cat heavily sedated to get the guide wire in there, though. So whatever you do, it's going to be hard.
It's going to be scary.
Yeah.
Okay, good. So I think we leave it here. It's a beautiful case, and I remember, Helen, I think we discussed about a trachea rupture in the clinic once. I think I remember that. And I remember trying to find this case and I couldn't find it. And then yesterday I was trying to find another case and this came across and I said, oh, cool, finally. I thought I tried to save the cases and I have a system to save cool cases. And then I couldn't find it following my regular system. And I thought I missed it. And now yesterday, just by coincidence, I found it. I said, okay, cool, this is the opportunity.
Yeah, that was a great case. Thank you.
Yeah, awesome.
And just back to the intubation thing, I just something popped up in my mind. I remember Kate Hopper talking about tracheal tears, but they were higher up. And they had a cat that basically they intubated and they just ripped the hole like massively bigger. And they used a jet ventilator. So they like jetted air past the hole while they were trying to fix the hole. So don't know this in the units.
Wouldn't you just inflate the animal?
Pardon?
It just seems like you'd inflate the animal.
Yeah, but they I think they managed to get it like past the hole and then they just like jetted. But it wouldn't work
like
in
really
the
high
because obviously you're way too far down. But Yeah. So I know in general they don't recommend intubating tracheal tears if you can avoid it for exactly that reason, because you just rip a hole even bigger.
Yeah.
Yeah.
I'm glad I wasn't seeing this one as a primary.
But Helen, we got a case. It was a tracheal rupture recently. Is that right?
I can't remember. I don't remember having one.
Okay.
But
well,
my memory's
maybe-
pretty bad, so we could have done.
Or there was a situation where that we consider that as a differential, and then I think I said, I'll try to find that case and we discuss. It may have been that.
Yeah, I don't
Or maybe,
remember.
maybe it was a dream. I don't know.
Yeah, maybe you made it up.
Reality from dreams.
Mariano, before we leave this case, and I might have vagued out and missed it, which I apologise, but going back to the mottled fluid, soft tissue density, ventral to the heart, did we decide that that was indeed fluid and or hemorrhage, or?
I don't think we can have a right or wrong answer. I think we can only have an opinion because we are in a tough situation. So once we have that pneumothorax, then our strong features of pleural effusion are gone. So then it's tough. I think I like the argument that you can still see the border of the heart. So the way that I would, if someone is asking me, I would say, I don't think there's a lot of fluid, but the patchy opacity is not pure fat. So I think that the patchy increased opacity, I would take it as a bit of effusion. That would be the way that I would take it. But I would immediately say, careful with this. You know, I'm not 100%.
Okay, thank you.
Mariano, I missed what you said about deep-chested dogs right at the beginning. Would you mind repeating that?
No problem. So, and I may have like a note about that. So the comment all came through, or second, as a consequence of the comment of the heart being elevated from the sternum. So that is a very, very cool feature, and it works 99% of the time in case of pneumothorax. And the way that it works is that the heart is kind of, if you want to think about it, when you put the dog or the cat, whatever, laying on the side, then the heart is actually kind of laying on a, if you want to think like a bed, and the bed is going to be the lung. And that's why it stays in that position. If that lung gets smaller because of pneumothorax, then that bed gets smaller. And then the heart actually, it's not that separates like this, it kind of falls. Remember that the animal is laying on the side. So then that's the argument, that's the mechanism why we see this in case of pneumothorax. So that's one consideration. Then after saying that, then we talk about the two situations where we may have that feature, that finding, that elevation of the heart that is not actually secondary to the pneumothorax. There are two other possibilities that may result in this image. So one of that Alex mentioned is the rotation. And the other one is, then is an anatomical variation. So the anatomical variation is a very deep-chested dog, very thin. So there is no fat in that mediastinum. The lungs are very well aerated. So you need to add to that combo is a very deep-chested, thin dog, and the radiograph was taken during deep inspiration. So if you have that combo, then the lung may go and wrap around the heart. And then if you take a radiograph at that time, then it looks like the heart is separated from the sternum. But it's not because the lung is small and the heart fall. It's because of the opposite situation. It's because now the lung went around, wrap around, and then resulted in elevation of the heart. So then it will be like a warning situation where anytime you call elevation of the heart and then you conclude that there is due to pneumothorax, those are the two things, exceptions to the rule to check. Make sense? Because then maybe you may be dealing with an exception to the rule that is disconnect the elevation of the heart from pneumothorax, and you may make a mistake. Is that okay? Make sense?
Makes sense.
Beautiful. Okay, so we'll leave it here for the suppose, unless there are more questions.
Thanks, Mariano.
Thank you. That was very
Awesome.
cool.
Thanks, Mariana.
Yeah,
very
cool
helpful.
case.